Hello, today we're going to talk about diseases of the genitourinary system. You know, not much to say about that. We all have one, right? I couldn't think of anything funny to say or interesting. So we'll, like always, go over the ICD-10-CM as well as the procedures with PCS and talk about the anatomy and the physiology. Whenever you talk about the genitourinary system, probably the first thing that comes up and one of the first diseases that you learn about coding is CKD, or chronic kidney disease. Chronic kidney disease is something that has a causal relationship with hypertension. So many people, you know, out there have hypertension. It's really, really common. But chronic hypertension over a long period of time, especially if it's not controlled, you'll start to see effects of the kidneys. And so often, you know, you'll see people with chronic hypertension end up with CKD, and people with CKD tend to have hypertension. So that's a causal relationship that is just, you know, something that you'll see in documentation a lot. With CKD, the first thing to remember is that there are stages of CKD. There's 5 stages, and it's really nice because the code for CKD, the N18 point, each the character right after your point is going to be what stage it is. So CKD1 is 0.1, N18.1. CKD stage 3 is N18.3, etc. And 2, CKD2 is mild, 3 is moderate, and 4 is severe. When you move past 4, you end up with end-stage renal disease, and nobody writes that. They always write ESRD. So commit that to memory, ESRD, because you're going to see it almost always written like that. Okay. Remember, I'll tell you if there's something you need to memorize versus something you just need to be aware of, and just go ahead and commit that to memory. And as well, the chronic kidney disease, we don't memorize a lot of codes. You know, we tell you don't memorize codes, but that's one you're going to see a lot. And there's a lot of guidelines. They like to throw those in on exams. So it would be a good idea to just, you know, commit to memory N18 point, you know, 1, 2, 3, 4. The reason I say that is that it would also make you faster at testing. Whenever you see a code that starts with an N, remember nephrology. It's going to have something to do with the kidneys in the genitourinary system, not the gynecological part, but it's going to have to do with the kidneys. The end-stage renal disease, ESRD, it has a code for itself. I think it's N18.5, which would be end-stage renal disease. A person that's an ESRD patient will be on dialysis. So you'll have a code for the dialysis, status code for dialysis. And again, that's classic testing questions. So be aware of that. When you have a person that has CKD, that doesn't mean that they'll be a candidate for a kidney transplant, but ESRD is. So they have to have dialysis when you're an ESRD patient. The N18 codes, and if you have a patient that is has had a kidney transplant, just because, okay, say there's CKD and they have a kidney transplant, that does not mean that the CKD goes away. Okay, sometimes they're no longer a CKD patient, but you can have a CKD patient be a kidney transplant patient. And there is a code for kidney transplant status, like I said before. I don't have that code memorized. I can't remember what it is, but you know, it will be in your tabular. There'll be a note there. So you might want to go in and look at N18 and find out what that Z code is. You don't have to have that memorized. Just be aware that just because a person's had a kidney transplant does not mean that they don't still have CKD, right? It's not a cure for CKD. There are other conditions often are coded with CKD. very seldom do you have a person that's a CKD alone. They usually have, typically, they'll have hypertension, and then a lot of times diabetes. Now, if you have a person that is a CKD and a diabetic, there's a causal relationship. So it's diabetic CKD, okay? And with hypertension, it's the same way, right? That causal relationship is assumed. You don't have to have the codes, the documentation telling you that the person has diabetic kidney disease, that they do, and hypertensive chronic kidney disease. It's assumed. Our urinary tract, the organs that are involved there is your kidneys, ureters, urinary bladder, and urethra. It's very common to get the ureters and the urethra confused. All right, so you have one urethra and you have two ureters, and there's laterality with the ureters. Okay. Most people, I think, kind of have that memorized, but if you don't, that you do need to memorize. And so you have two kidneys, two ureters, one bladder, one urethra. The reason for our urinary tract is to get rid of the urine, which is a form of waste, and our kidneys filter. Okay, and then of course the bladder stores, and then you get rid of the urine through the urethra. The kidneys are actually, everybody pretty much knows that the kidneys are in your back, but they're not down by your waist. They're not right there, by your hip bones, like most people think. They're very high up in the back. They're in the lumbago part, but they're down. The rib cage does not protect the kidneys. They are actually just kind of right under the rib cage, and then out a little bit from the spine. And a lot of people don't realize they're up that high in the back. I just like to note that, because when a person has kidney pain, they call it flank pain. And that is an indication. Sometimes people will think they have lumbago, low back pain, and if it's up a little bit higher, that it could be the kidneys involved. Your kidneys, they're shaped like beans, kidney beans. That's where they get the name for those kidney beans, and they kind of look like those red kidney beans themselves. They filter the waste, but it's out of the blood. They filter the waste in the blood, and they create urine to get rid of the waste. One thing, your urine is sterile, if you didn't know that. And in the past, we don't do this anymore, but a long time, pre-Victorian, I'm trying to think, Renaissance type age and stuff, they used to clean their teeth with urine. Now, we think that's completely disgusting, but if you think about it, your kidneys, your urine is ammonia, and ammonia bleaches. The problem is it would also eat the enamel off the teeth, and your teeth would rot out. But that's where the term pith mouth came from, if you didn't know that. A little bit of history there. Okay, so again, to keep the teeth nice and white, that's what I guess the aristocratic people used to do. Now, let's see, your ureter, each kidney has a ureter that comes down off of the kidney. You have two ureters, and one of the interesting things is they've got to come down to the bladder, right? And so they come down and then they curve a little bit and then go into the bladder. And when people get stones, a lot of times they get caught right there at that curve before it goes into the bladder. Also, I thought this was a funny statement. The urine travels from the kidneys to the bladder. It's a one-way street. There is you don't want any regurgitation or backflush and stuff, but there's no valves or anything to stop that. But it's kind of pressurized. Okay. So the urine just goes one way. It doesn't go back up. It goes one way. then of course the bladder just holds the urine, but it is like a stretchy, elasticy tissue. So let's say they want to do some type of ultrasound or on anything in the low abdomen. A lot of times they'll make you drink lots of water. They want that bladder to expand, and so it pushes everything up so that they get a better view. Right. And then there are times they want the bladder completely empty before they do scans and things like that, because it is stretchy, it takes up space. The urethra travels from the bladder to the outside of the body, and it's a little bit different in males versus females. The males is a little bit longer, of course, but that's because it's external, whereas with females it's internal. The male genitalial tract, we've kind of gone over this a little bit probably in other slide decks, but this is called the reproductive tract as well. You have the testes, the epididymis, the vas deferens, the seminal vesicles, the prostate, and the penis. And of course, the main reason for the testes, epidermis, all this other stuff is for the production and transportation of sperm. The diseases that happen to the male genital tract will often be infertility. You can have infection, like urinary tract infections. You can have tumors, and you can have problems with the prostate, which isn't mentioned here. And that's probably the number one thing there, is because it just seems like, reading all this documentation through the years, men have trouble with their prostate after they get to be a certain age. It's very common. Whether the prostate just is enlarged or prostate cancer. Just because the prostate's enlarged does not mean you have prostate cancer, by the way. So with the female genital tract, we have the vulva, the vagina, the uterus, the fallopian tubes, and the ovaries. And again, primary function is reproduction, but the diseases that are associated with the female genital tract. Now, of course, we have infections like UTIs that happen with the urinary tract, but you can have infections, tumors. Probably the number one thing tends to be hormonal disorders. So just like when the men get to be a certain age and they have problems with their prostate, women go through menopause. And I like to think that that is God's way of evening out the sexes, that we have to go through menopause and men have to deal with their prostate. And of course, pregnancy, because notice it says diseases and conditions, and by far pregnancy is the leading thing that we discuss with the female genital tract. For both men and women, we have breast tissue. Surprisingly, a lot of people don't realize that men can get breast cancer because they actually have breast tissue. Now, they don't have the same ability to lactate like women, but they do have that. We do have the same breast tissue there. When you go to code for breast cancer, a lot of the codes will ask you male breast cancer or female breast cancer, and treatment is the same. So what would happen with a man that has breast cancer, they would have removal of that breast tissue just like a woman with a mastectomy. It's just there's not as much tissue involved when you're dealing with that. So again, it can affect both male and female. Now we're going to talk about conditions specifically of the genitourinary system. One of them is called glomerular disease. Now, this is specific to the kidneys, and this is a nephritic syndrome or nephrotic syndrome. It's kind of synonymous. Your if you're going to go see a specialist for your kidneys, you see a nephrologist. And that's how you'll remember that anything to deal with the kidneys or the urinary system will start with an N. Those codes are going to be N codes. One of the condition is proteinuria, and literally just means you're spilling protein into the urine. Now, for the most part, I think of this for women who are pregnant because they check your urine frequently. For a woman to be spilling during pregnancy to spill protein in your urine is a bad thing. You know, we all spill a little bit of protein, but to have larger amounts, that means there's something going on that has to do with hypertension. And we don't want pregnant women to have hypertension because there's associated problems with that that can affect the women and the baby. Ultimately, you could have a stroke. So one of the indications that your blood pressure is getting really high is you spill protein in your urine. So we don't ever want to have high levels of protein in our urine, but we do spill the protein in the urine because it is a filter system. Signs and symptoms will be low levels of protein in the blood, swelling of the eyes, feet, and hands, and we can have hypercholesterolemia. Now, hypercholesterolemia is different than high cholesterol. This is a specific type. If you want to know more about that, write that down, hypercholesterolemia. It is a different code than just having high cholesterol. And go look those up and study the differences in them. Signs and symptoms and everything is similar, though. There are other things that can happen to the kidneys that are very common. We have nephritis, nephrotic syndrome, and nephrosis. We have another condition that's abbreviated GN, glomerular, ulnonephritis, if I said that right. That is when the glomuli of the kidneys are inflamed. So if you look at the anatomy of the kidney itself, take some time to do that. You can go Google image that and see the glomuli that make up the kidney. Different things can cause that part of the kidneys to swell and get inflamed, but for the most part, it's a temporary condition, but it could be permanent. Really, the other thing that is the most severe that can happen to the kidneys is ESRD, chronic renal failure, when you have nephritis and things like that, because the kidneys, they kind of repair themselves, unlike the heart and the brain. That tissue, once it dies, it's dead, but the kidneys are actually quite durable. We also have a condition called renal interstitial disease, and this is when the structure of the kidney outside the glomerulus is affected. You have not only do you have the glomerulus, you have tubules and interstitum of the kidneys, and not the glomuli. Now, these terms you're probably not as familiar with because they're not things that we talk about very often, unlike the heart itself and the anatomy of the heart. The kidneys is, unless you are in nephrology, you might not see this as much. But unlike the brain, where you have meninges, that's spelled different. But anything that has a G in it, it's either going to be the nervous system off the brain and the nervous system, or it's going to be the kidneys. So little heads up, G words as far as anatomy tend to be those two areas. There are other things, but think to yourself, okay, but meninges, okay, that are glia cells, and these are glom, okay, the kidneys. Whenever you see GLO, that's the kidneys. I don't know how you're going to memorize that, but think of a way to associate those words. Other types of renal tubular interstitial diseases is pyelonephritis, and this is going to affect the kidneys and is considered an upper UTI, urinary tract infection. Now, memorize UTI. For the most part, that's just common lay verbiage for everybody. We know what a UTI is, right? They'll say, oh, I have a urinary tract infection. They say, oh, I got a UTI, or I feel like I've got a UTI, because that's common. That's almost as common as getting a cold. What happens is you get some type of an organism, usually a bacteria, that gets into the urinary tract, and it literally starts in the urethra, gets up into the bladder. Now, if it stays in the bladder, then 7 days of an antibiotic can usually take care of it. Signs and symptoms, fever, pain and urination, things like that. But if it goes up into the kidneys, that's a little bit different, and you end up kind of tend to get like 14 days of antibiotics for something like that. Fever, chills, and stuff like that. Anything that you have associated with having a bacteria in the body will be similar when you have a UTI. Symptoms, of course, are going to be dysuria, flank pain, and costovertebral angle tenderness, which is, costo is the ribs, vertebra is the spine, and so between the spine and the rib cage, called angle tenderness. So you have your rib cage comes down, like here's, it's connected to the spine, it comes down like this, and so the spine is here and the ribs stop here, but that pain will be right there, kind of at that apex of where they meet. But your kidneys are not really there. The reason boxers aren't allowed to do kidney punches is because there's nothing protecting the kidneys, technically. Okay, so down at the base of where the ribs are and where the spine is costovertebral angle. Another one is vesico-retral reflux. Now, again, you don't have backflow of urine normally. Okay, it's not normal to have that happen. If it does, then that's an abnormality, and it can cause problems, because it is that's more or less a sterile tract. But if any organisms get in there and you get backwash, then what are you doing, right? That's like the only thing that comes to mind is like using somebody else's toothbrush. You're going to get out there and get some organisms, and they're going to come back up into this sterile environment. It's not going to be good. Hydronephrosis is when you have dilation of the renal pelvis. It's abnormal and caused by pressure in the urine that cannot flow past an obstructed urinary tract. So it's literally it's not an aneurysm, because you don't have a weakness of the structure, but you have bulges because you got pressure buildup. And this is something that can happen like when you have a kidney stone. That's could be a condition where you've got this flow, you've got this tunnel, and it's very small, and a stone gets caught, and if the urine can't get past that, everything else will start swelling, because there's the flow. Think of that creek that or your not aqueduct, what's it called when the little ditches and stuff like that. What happens when that duct to let the water flow through gets log and debris? When you have flooding, it's going to flood out even more, right, and cause problems. That's what hydronephrosis is. We have hydroureter, which is accumulation of urine in the ureters. We don't want that to happen either, right? That can cause a lot of pain real fast, because the ureters are very, very tiny, and they are, not even as big as a regular drinking straw. They're smaller than that. I don't even have they're, we're talking like they're probably smaller than this, or just about this wide. So again, we don't want that swelling. You would not code that unless you have the documentation to don't assume. Now, acute renal failure is different than what we've talked about before. ESRD is chronic. It's end-stage renal disease. Acute renal failure usually happens when things like you can have sepsis, you can have trauma to the kidneys, and the kidneys shut down. you know, when they check blood levels, you can have a heart attack and have acute renal failure. The kidneys are one of the first things it tends to be that start being affected when something else is off in the body. The kidneys start reacting and shutting down. So acute renal failure, or ARF, is a sudden problem with the renal function. Now, this is all function, everything that we've already talked about. Signs and symptoms are going to be oliguria, increased serum urea, meaning they can see that in the blood test, and acidosis. Now, when you have acidosis, again, this can be checked, and it's literally what it sounds like. You start having acidity in the urine. Sometimes you'll see terms called acute kidney injury instead of ARF, but we're talking about it's similar, except for if it's non-traumatic injury, the acute code is N17.9, non-traumatic. But let's say a person, well, you could get punched in the kidneys, you know, or something, and have the kidneys swell and shut down. It's like getting punched in the eye. Can you imagine? Think of your kidney as your eye and how tender and delicate that is, and you got to protect it. And the kidneys are just kind of sitting there with no protection except for, you know, the body itself. So I guess they're not exposed like the eye, but be very, very careful that you do not code CKD as ARF. And ARF is not CKD, but you can have both. Okay, you can have a CKD person that goes into acute renal failure. Okay? And you know, you've probably seen in TVs or something, you know, or even if you've had people, friends and family that may be in ICU, and they'll come in and say, well, the you know, their kidneys are shutting down. That's what they're talking about. And they can tell that very quickly by the blood tests. Sometimes it's just temporary. The kidneys shut down because the kidneys are swollen or damaged, or an infection just takes over and everything. But it could take a long time to actually resolve. If you go into renal failure, if you go into acute renal failure, you still have to be dialysized. I mean, the kidneys aren't working. And if you get acute renal failure, it could turn into CKD depending on how extensive the damage is to the kidneys. When you're looking at the documentation, things that are going to give you an indication that things are going wrong with the kidneys, you're going to see elevated serum creatine. Whenever you see anything that says creatine, they're talking about the kidneys, and this is how the kidney flushes out the muscles. So people can take creatine. Bodybuilders and people that are athletes, a lot of times they'll take creatine, and it'll stop the pain in the muscles because it allows the muscles to get rid of the toxins that are developed because of stress on the muscle. So creatine, every time you see that, they're talking about kidneys. BUN. Oh, hold on just a second. Looks like we're having problems with our internet. Let me just double check real quick to make sure that I'm on my proper internet. I apologize. We'll have to edit this out. Just look real quick because I don't want it to shut down. Okay, we are doing good. Sorry about that.
You're okay here, Alicia.
Okay. It kind of freaked me out there. I didn't want it to be a problem. I'll go back to the slide 17 then. Did you see that pop up? That warning?
It
popped up on my screen. A thing popped up and said.
I didn't lose you, but so you're okay.
Okay. So again, you're going to see serum creatine, BUN, and another term they say is diminished creatine clearance. In other words, it's not flushing. You'll also see the documentation talking about a degree of renal impairment. So those are the key terms that you see associated with that. Now, CKD is pretty common actually out there. Just like hypertension is very, very common, diabetes is very, very common, CKD is relatively common. So common that there is a National Kidney Foundation. And we've already talked about the stages, right? 1 through 5, which 5 is renal failure. Then ESRD, being renal failure, is different than CKD, okay? When a person is an ESRD patient, they have to be on dialysis. Once you have started dialysis and require dialysis, I think you can go like 3 days, but not 4, I think, without dialysis before you'll succumb. The rest of the body will shut down. And so you may or may not have heard of people that have chosen to stop dialysis. And if they're an ESRD patient and they choose to stop dialysis, then you know that it's a matter of days before they succumb. Now, I talked earlier about the kidneys getting rid of waste, but they don't really excrete waste like the digestive system. So that's not really an accurate term to have said that it, because it doesn't really secrete waste. It filters the blood. And I think of it as filtering the waste out of the blood and the fluids, like the lymphatic system. But technically, it's not considered waste. Okay, so if you get a question, you're not going to get a question like that, but don't repeat what I said and say, oh, well, the kidneys, filter waste, because technically they don't. They do filter the blood, and I think of it as waste. That's where you get into those things where they say, don't do what I do or do what I say. I can't think of that little term, but you know what I mean? Take that with a grain of salt when I say that. Because when we think about the kidneys, they're getting rid of that filtration, but it's actually sterile, unlike what comes out of your digestive tract. Dialysis or kidney transplant is ultimately what happens with end-stage renal disease. Is a patient is going to have a transplant. They'll be on a transplant list. There is a whole area of study on transplant. You would be surprised the things that you don't understand about CKD and or ESRD and the process of transplants. A lot of people don't realize that when you have a kidney transplant, very seldom do they take your kidney out and put a new kidney in. Unlike if you do heart or lung, right? There's no room. But with the kidneys, they'll leave the diseased kidney in and just make an area for the new kidney. So you can have 3, 4, 5 kidneys, actually. Now, they do take out the kidney if it's diseased to the fact that it's necrotic or there's cancer involved, then they would. But because what it's doing is it's not working effectively, right? It's diseased, but it's not dead or dying tissue. It's just not working at the percentage that it needs to work at. And so that's interesting. Whenever you do kidney transplants, the coding is delicate because you have codes for harvesting the kidney, whether it be from a person that is going to succumb to a person that is like a family member. So you have to harvest the kidney. So a team does that. Another team, surgical team, makes a place for the new kidney. And then the third surgical team does the actual transplant of the kidney, right? So there's a lot of codes involved, but it's very repetitious codes. Hypertension and chronic kidney disease are their causal relationships. So you'll see them coded often together. Now, this is called hypertensive renal disease, okay? And you're going to code a different, you will not have a patient that is an I-10 for hypertension and N18.4. No, it's a different hypertension code. And I can't remember if it's I12 or 3. I can't, I think it's I12. Go look and see. I'll tell you wrong if I try to do it on top of my head. So again, whenever you have a CKD patient that is hypertension, it is not I-10. That is a dead giveaway for you for testing purposes. If you have multiple choices and you see the N18 point something and then I-10, those codes don't go together because it's a causal relationship. It is CKD, it's a hypertensive kidney disease, which that's a different hypertension code. That is a causal, you assume that relationship. Check the documentation because there are incidences. It has to be documented if the CKD is not related to hypertension. Okay, so we assume it, we always put it together unless there's a reason for it not to be put together, and the documentation has to blatantly state that the patient has hypertension and has kidney disease and they're not related. Another problem we mentioned that is causal is diabetic nephropathy, or you know, diabetes and having some type of renal dysfunction, and nephropathy is one of the leading ones. What happens is when the diabetes isn't controlled, it affects the kidneys. Now, that doesn't mean that the patient is not compliant. Okay, don't confuse having your diabetes in control and being compliant as synonymous. It's not. Not being compliant means that you've got Twinkies hidden under your pillow. Okay, that's not being compliant, not taking your medication properly, not taking, you know, your insulin when you're supposed to, etc. You know, whereas not being in control means your body is not able to control your diabetes, and everything that they do as far as medication and stuff like that aren't helping. Okay, so your blood sugars are up and down, but it's not a person's will that's doing it. It's the body that's not controlling it. So whenever you have diabetes that is not controlled and up and down, it's very common to have kidney issues as well, and nephropathy is one of those. Not only is there the other types of nephropathy is glomerular sclerosis, pyelonephritis, and papillary necrosis. You can go and look at those a little more, but they are all considered diabetic nephropathy. Okay, diabetics are prone to UTIs, which end up causing scar tissue and causing more damage to the kidneys. And you think, well, why is that? Well, think of it as far as the disease process goes. What do we have with the bladder and the kidneys? Warm, moist, dark space. Okay. What grows in warm, moist, dark spaces? Bacteria. Now, throw a little sugar in there because when a person is diabetic, they have higher levels of sugar in their system. The insulin can't regulate that sugar. So it's just like making bread. You know, if you go to make homemade bread and you got your warm water and you put your yeast in, and then you put your sugar in on top of that yeast, and it feeds the yeast and activates the yeast faster. That's exactly what we're talking about with the kidneys and the bladder. So, you know, that's one of the reasons that they're prone to infections. Let's see, diabetes and CKD are assumed also. We talked about that. Urolithiasis is when you have a stone. Calculi is the medical term for a stone, and you can have urolithiasis, which is a buildup of fluid. A stone, or is a stone also. So you could have a stone anywhere. You can have it up in the kidney, you can have it in the ureter, you can have it in the bladder, and very seldom does it get stuck in the urethra though. But remember I told you the ureter has that curve in it, and they really like to get stuck right there. And for women, that's about right where the ovaries are. And so, you know, sometimes like, well, okay, is this a problem with the ovary or is it something else? And if they go check your blood, they can say, oh, we got, you know, your BUN or your creatinine, something's off a little bit. And they'll say, oh, it might be a stone, or you have blood in your urine. So how do they treat for kidney stones? They have ESLW, which is a type of lithotripsy, and laser lithotripsy. The thing is, though, they don't use lithotripsy unless the stone is of a certain size, and it has to be like 6 centimeters, I think, between 6 and maybe it's 7. I can't remember what protocols may be different. I think it's 7 centimeters. The one stone, I've had many a stone because I have a kidney dysfunction that I like to fondly call wonky kidneys, but which is not chronic kidney disease. But the the one stone that put me in the hospital down on my knees and the worst I've ever had was only 5 centimeters or millimeters. You know, it's very, very tiny. 5. So think of it, those little 5 millimeter beads that you go and do crafts with. That's how tiny that was. And I thought I was dying. You know, it was worse. I told the doctor I'd rather be having twins breech without an epidural. It was that bad. And it was too small to do lithotripsy. So they actually went in and did surgery and went to grab it. And there was 3 stones in my kidney and 1 that was caught and hung up in the ureter. Now, renal colic is what they cause, that is the term for that pain that you have whenever you have a stone that's caught. Renal colic. UTI, we've already talked about that, and that is an infection, usually bacterial, and there'll be some type of organism involved. We will have cystitis, urethritis, or polynephritis are the terms for that off of UTIs. If it is the bladder that has the infection, then it is called acute cystitis, and but it can spread up into the kidneys. If you have a UTI not otherwise specified, or NOS, that means that it's not stated whether it's the bladder or the kidneys. But you could have acute cystitis and a UTI, and you only code for the acute cystitis. Now, physicians often will just say UTI when they mean cystitis, urethritis, or polynephritis. Okay, so pay attention to that. Always know you can query, but they tend to just say UTI as a catch-all. Bacteria, again, is the #1 reason that most people get a UTI, but you can have viral, fungal, and parasitic infections as well. And you can also have an STD that causes a UTI. The detection is, excuse me, they just go do a culture of the urine. You know, they do a stick test first. It's very common to see blood in the urine. If you have blood in the urine, sometimes they start thinking there's a stone involved, but you can do a UTI and it'll identify the bacteria. Let's see, the bacteria that tend to be the most common are going to be E. coli, Staphylococcus aureus, and group B, Streptococcus. All 3 of those are common UTI causes, and they'll send it off and do a culture. Often, you know, they can do a stick and say, oh yeah, we see bacteria or white blood cells in your urine, and they will maybe give you an antibiotic, and they say, but you know what, we're going to send this off for a culture, and we're going to make sure that the antibiotic we give you is the best one for what is comes up in the culture. So certain antibiotics work better on E. coli than they do on Staphylococcus, et cetera, et cetera. And then they've got some that'll catch all of them. There are incidences when you have recurrent UTIs that they may put you on an antibiotic like Macrobid for an entire month to try to kill whatever it is that's in there. And so again, when you are working with urologists, you see things like that more often. You can have the documentation has to be done by the provider. So just because you have a culture done and it says that it's E. coli, you don't code for E. coli. The doctor has to put it on there. And a lot of times you don't have that report doesn't come in until afterwards. You know, now if you're in-house in the hospital, you'll have it a little bit faster, but these cultures take a little bit of time because they've got to develop. Okay, so in the beginning, you may not know what it is, but by the time the patient was discharged, you probably do if it's in-house. So then always the way you code that is the UTI first and then what the organism is. And the tabular will direct you on how to do that. You can have chronic or recurrent UTIs. That's where I told you they could put you on medication for like a month, like that macrobid was a common one that they used to do. I remember I had done that. Now, when you have a dysfunction or something wrong with the kidneys or the urinary tract, then current or chronic recurrent UTIs is common. Now, until they figured out what was wrong with my kidneys, this is something I lived with ever since I was a child. And so I was always on antibiotics and stuff. And you'll find with older people, they may not have the signs and symptoms of the UTI, but they'll have a diminished cognitive abilities. All of a sudden, they don't even realize they have a fever, but they start acting a little different. You know, they take them to the hospital. One of the first things they'll check them is, hey, do they got a UTI? Because it affects the body pretty severely. Right, without even having the symptoms that, you know, you or I, if your urine burns, man, you're in there getting relief, right? But they don't have those signs and symptoms all the time. So you can have additional codes if you have chronic or recurrent. Pay attention to long-term antibiotic usage. There's a code for that. And you can also append a code for a history of UTIs. Okay, because remember, statistically, we want to capture that. We want to, and for my treatment, they wanted to track it because, again, ultimately, all that documentation and stuff allowed the nephrologist to figure out what was wrong with my kidneys. So another condition is urosepsis. This is, be very careful with the term urosepsis because your providers tend to throw this term around, and it doesn't mean the same thing for us as it does for them. You know, you need to query the provider. There isn't a code for urosepsis because what we call urosepsis or septic, right? Sepsis is a whole protocol and guidelines for sepsis, but that's not what they're saying it is. This is like a UTI for them. So don't code unless you know for sure that this is urosepsis. And then the documentation, you may have to query the provider for more information. Urinary incontinence, very common. This can happen to men and women. It can be age related. It could be due to stress incontinence when you have women who have had lots of babies. The bladder falls a little bit and then it results in having problems with incontinence. We always laugh as women that, you know, we can't sneeze without wetting ourselves, you know, when you get to be a certain age. Or if you're pregnant, you're going to suffer from that, right? Because the pressure of the baby on the bladder. But this is not something that just happens to women. It happens to men. And you'll see that anything that men would do that would cause stress on the bladder, like weightlifting, things like that, you know. So medical concerns, well, incontinence doesn't really bother a person as far as getting infections and everything, because the urine's going one way. But your lifestyle, right? You know, if you never know if you're going to sneeze or cough and you're going to wet yourself, that's a problem. Another thing is, it's one thing to have a little bit of incontinence once in a while, because that just happens as we age. It's just, you know, everything wears out. But the sphincters that hold the urinary flow in wears out. It's elasticy, right? Like having a slip where the elastic wears out after age. But it becomes a problem when you can't retain the control over your bladder for larger amounts. And we have skin integrity. So with the elderly, if they have this and don't get proper care, or maybe that's, you know, like Depends or something to keep themselves clean and dry, we can have breakdown of the skin. And then you're promoting infections of the skin and ulcers and stuff. But know that it affects men and women the same. However, women tend to talk about it more, I think. There's different types of incontinence. I already mentioned stress incontinence. Urge incontinence is, you know, it comes on suddenly and you just have to go to the bathroom. Stress incontinence is, you know, you have a little bit of leakage when you sneeze or you squat or you cough, right? If you have, one time I remember that I had pneumonia, and it was so bad that I would cough and cough and cough, and you're holding your knees together because, you know, you have to go into the bathroom, sit on the toilet and cough because you're coughing so hard and for so long with that pneumonia. And I was always scared that I was going to wet myself. Urge incontinence, again, is a little bit different. Mixed incontinence means that you have a combination of both. Overflowing incontinence means there's just always a leak. It's almost like the tap isn't turned off completely. Functional urinary incontinence is physical, or it could be a mental condition that prevents a patient from making it to the bathroom. You know, and again, this is where you're looking at more with the elderly people. They can't get to the bathroom. Maybe because they don't know to go to the bathroom, because of Alzheimer's or something like that, senility. Diseases of the male genital organs, of course, prostate tends to be the #1 thing that we talk about. You know, it's like you turn 65 and your prostate falls off. Is like I like to tell people, which your prostate doesn't fall off, it swells up is what happens. And inflammation, enlargement are the #1 things. Well, when this happens, it causes a urinary flow problem, because the prostate is right there where the urethra, not the ureters, but the urethra comes out, and that swells up, and it's almost like turning the tap real tight. Okay, and just letting a little urine out at a time. And so it causes a lot of problems. You can have benign prostatic hyperplasia, or you can have benign prostatic hypertrophy. What happens is you have to go to the bathroom more often. Yeah, frequency. Nocturia means you have to get up in the night several times and go to the bathroom. So again, getting back at men for women being pregnant and having to get up 4 or 5 times in the middle of the night to pee. And then another condition called lower urinary tract symptoms, or LUTS, L-U-T-S. You can have prostatitis, which it can be either chronic or acute, which is an inflammation of the prostate. Most of the time it's bacterial, but it can be non-bacterial. And whenever you have prostatitis, they're going to ask you if you know what the organism is. You want to identify that. So it's going to be like an A or B code. PSA, that's something that you're going to want to memorize. This is prostate specific antigen. For men, just like women go in and every year and have gynecological exams, and we have our pap smears, we have mammograms and stuff like that, men need to have their PSA level tested, because that is going to tell us if there's something wrong with the prostate. When you have a protein produced in that prostate gland and it's elevated, it can indicate that it's cancer. Now, not all the time, but I did ask a urologist one time that, you know, if you have an elevated PSA of, and there's a range, and I said, because my father got prostate cancer, and I asked him, and she goes, oh yeah, that's always prostate cancer. So again, the PSA level, you'll have that tested, and it's a blood test to be able to test it. Very easy to have done. Disorders of the breast can affect men and women. We already talked about that. Mastitis, which is an inflammation, or you can have infection of the breast tissue. What they do is they can give you an antibiotic, but if they have to, they could go in and do an IND, an incision and drainage. But not always does that have to be done. Antibiotics can take care of it. Sometimes women that are nursing will develop mastitis, and the breast will get very, very hard and painful. Mastectomies can happen with both men and women, but it's prophylactic breast removal. We're taking the breast so that we don't get breast cancer, or we have breast cancer and we're just getting rid of the tissue. Often when a person goes with women, they go in and have a mastectomy, you're going to see either at the same time or staged reconstruction of the breast. You know, some women choose to not have reconstruction, and other women do. A lot of the times it depends on the age, whether they tend to have choose to have reconstruction done. Inflammatory disease of female pelvic organs. PID is one of the most common pelvic inflammatory disease. You can have salpingitis, which is the fallopian tubes. That's the most common, but you can have also endometritis, which is the uterus, and then you can have oophorytis, which is the ovaries that can be inflamed. So commit to memory that salpingo is the fallopian tubes. Whenever you have endometrius, usually means the uterus, or the lining inside the uterus, because you can have endometriitis all over, because the tissue inside the uterus can get out and get into the abdominal cavity. And oophorytis, remember, oof is for the ovaries. So if you go in and you have a, say someone's going to go have a hysterectomy. So hysto is uterus. They don't sometimes just have a hysterectomy. They could have an oof hysterectomy, which means they're taking an ovary. If you have an oof hysterectomy, they're taking the ovaries and the uterus. If they're having an salpingo oof hysterectomy, they're having everything taken. So just memorize those terms. Endometriosis, I already said something about that. That's chronic. And what happens, again, is the lining of the uterus is a special type of cell and tissue. So for women, that endometrium it goes through cycles, right? Just so it gets inflamed and it gets spongy, and then because it's preparing for fertilization, that fertilized egg to attach, and if one doesn't, then it sloughs off, and that's why we have menstrual cycles. But if that tissue gets into the abdomen, and it can attach itself wherever it wants. It can attach itself outside of the uterus. It can attach itself to the intestines. It can even go up and attach itself to the lung. These are and everything. So then it would, every month it would get inflamed, right, and cause problems. So it really, the only way to tell really is to go in and look, do a laparoscopy, but they'll usually put people on, women that have signs and symptoms of endometriosis, they'll put them on birth control pills, and then they won't let them cycle. So therefore that tissue doesn't get inflamed and cause the problem. My mother had this very bad. My daughter has this, and the medication works. Now, my mother has had a hysterectomy, so she didn't have to worry about that anymore. But the codes will be based on where the endometriosis attaches itself. And again, the most common places that attaches the ovaries and the fallopian tubes, but it can attach itself anywhere in the abdominal cavity, honestly. Another condition is genital prolapse. This is where all of those organs in there start to slip and move. If you have protrusions in the vagina or the wall or the vaginal vault, you can also have weakness or damage in the ligaments and muscles of the connective tissue, so everything starts to slip and hang a little bit. This can also happen with the bladder. Contributing factors, genetics. Maybe it's just in your genetics to everything loosens and that's just, you know, it's like some people are genetically predisposed to having more wrinkles than other people. Pelvic surgery. So scar tissue builds up, or we've weakened by going in there and doing procedures. Pressure within the abdomen, weightlifters, right? And history of childbirth. So the more times you have children, the weaker everything is in there. As many times as I've been pregnant and the many children as I have birthed, surprisingly, everything is doing very well for me thus far. So I'm very happy about that. But my daughter, who is pregnant with number 5 in 5 years, she's starting to have a little urinary problem. And so she'll never see this lecture, so she won't mind me telling you that. But again, if you think about that, the body doesn't have time to heal between those and stuff, and so everything gets stretched out a little bit. Other genital prolapse, of course, uterine prolapse. We talked about the uterus and the cervix can all fall down into the vaginal vault or the vaginal canal. Cystocele is when you have problems with the bladder actually presses on the wall of the vagina. You can have urethrocoele, which is the urethra presses into the vagina, and sometimes you can have cystocele and cystourethrocoele together. Retrocoele is when the rectum comes in, and then the vaginal vault prolapse, where that can happen after a person has a hysterectomy and the top of the vaginal vault tends to fall in there. Fistulas happen all the time. So that is just an abnormal passage. You got communication between 2 organs. So one of them would be urethrovaginal. And so between the urethra and the vagina, it hardens and gets an abnormal passage that opens up in there. Let's see a vesicoureterine fistula, which is the bladder with the uterus, vesicovaginal fistula, so the bladder with the vagina, and a vesical fistula, bladder with the rectum. And again, these are abnormal passages or openings that can happen. We can have cervical and vulvar dysplasia, and cervical dysplasia means that you have abnormal cells in the cervix, surface of the cervix. This is percutaneous. This is goes in not just on the outer layer. You can have squamous, think of like squamous cell carcinoma. This is squamous intraepithelial lesions. So you can have dysplasia and identify those on pap smears. That's one of the reasons that they do those. Cervical intraepithelial neoplasia is doing a biopsy of the cervix, and you can have vulvar intraepithelial neoplasia, which is when you get the skin that covers the vulva itself has bad cells. So now let's talk about the Z codes that are common. The Z codes that are the most common that you're going to see affecting these areas are infection with, okay, organ or tissue replaced. So we're talking about transplant. Artificial opening status. You can have a ureterostomy. Absence of an acquired absence of an organ. So we had something removed like a hysterectomy. Encounter for. So we're having an encounter for screening of, or we got special screenings for, but encounter for, you know, well, that would screening would be a pap smear. I'm trying to think of one. I can't think of one. Aftercare, after a procedure, attention to a urostomy or pessary device, and special screening for pap, we'd say, or prostate. Medications that you'll see used, antibiotics, you're going to see antibiotics used for glomerular nephritis. Now, these are all things we've already talked about: cystitis, uritis, pyelonephritis, stones of the urinary tract, calculus of the urinary tract, prostatitis, and mastitis and PID. All will have antibiotic or given antibiotics. Anything you have an inflammation, you're probably having an antibiotic. Treated by fluids. Whenever we're going to put a person in the facility with IV, acute renal failure, of course, and you're limited with the amount of fluids that they give you when you have acute renal failure because your kidneys can't process the fluid. So you got to limit it and be careful. Cystitis, kidney stone, and mastitis all would be put on IVs. Medications that managing different things. I already mentioned the endometriosis. A lot of times the most common treatment is to put you on birth control pills, and then you don't take your 5 pills placebos to have a cycle. You just never stop. So you do your 28 pills and then you start a new pack again and again. They don't let you go through cycles. Glomerular nephritis, urinary incontinence. There's medications to help tighten up that sphincter. Benign prostatic hyperplasia again. And actually for prostate conditions, swelling of the prostate, one of the best medications for that is the little blue pill. It works for that, but the insurance won't pay for that because it is also used for erectile dysfunction. And so that's too bad because it also works with enlarged prostates. Skin and breast procedures. Now we're talking about PCS, your procedure codes. So if we do anything to this, remember the breast is classified as skin, not on it is not classified as part of the female reproductive system. It's classified as skin. So OHO through OHX. Urinary system is going to be OTI through OTY. Now, again, it's the second character that we're dealing with. That is the body system. The third character is going to be your root operation, the procedure that you're going to be doing. So that's why you're getting the range. Female reproductive system will be OU. Male reproductive system is OV. Administration, if we're going to administer something, that is 3, 0, 2 through 3, E1. And these are all tables that you'll go to. Extracorporeal assistance and performance is going to be 5A, O through 2. Now, you can go to the tables, which would be like the tabular of your PCS manual, and you can look at these. And it would be a good idea to go do that. So take some time and go to the table OH and then look at all the options of the procedures that can be performed to the skin and breast. The same with all of these. A little light reading as you go through. You can't code sometimes until you know what the options are. That'll make you have the ability to code to a higher specificity. It'll also make you faster. Another procedure that we need to be aware of is for dialysis. Whenever you have a patient that is an ESRD patient, they will be on dialysis. But chronic kidney disease isn't necessarily going to have dialysis, right? End-stage renal disease, yes. Kidney failure, you will. Hemodialysis will be putting you on a machine, a hemodialysis machine, and it removes the waste from the blood. Instead of the kidneys doing it, this machine will remove will process the blood. You can be connected with an AV fistula that's created in the arm. Usually they'll put in a fistula and then you'll just plug the machine into your arm. Sometimes you have an AV graft that's permanent access. You can use hemodialysis at dialysis centers, and often you're in 3 times a week. It's not like a once a week or twice a week. You go in 3 times a week and you sit there for 3 to 5 hours and let the machine process your blood. So it's a commitment because remember what I said earlier, 3 to 5 days before you succumb. Dialysis can also be done, peritoneal dialysis, and what this does is it's an internal. So you have a solution that filters out the waste and the excess. You can have continuous ambulatory peritoneal dialysis, or a CAP D. This takes about 15 minutes, and you do it 3 or 4 times per day and once at night. There is also continuous cycling peritoneal dialysis, CCPD. That is where you have a cycling machine, but where you plug yourself in at night, and then it processes. And then sometimes you can have more than one method that's done. So these others you can have done at home, right? You don't have to go to a dialysis center to have those done. Then, of course, we have kidney transplant. There is a status code for kidney transplant that will follow the patient from then on. There's more than one type. You can have a live related donor, or you can have a live non-related donor, or you can have a transplant from a cadaver. And so again, there is a different codes associated to each of these. And remember, there is a team to harvest the kidney, and then the team to make a place for the kidney in your body, and then a team to connect the new kidney. There's all kinds of complications that can be involved, but the one that we think about most is rejection. And I do have a friend that I went to school with. Her brother has had multiple kidney transplants, and a couple of those has been rejected, and that's why he has more. Whenever you have any organ transplanted in the body, kidney or anything, you are on anti-rejection medications for the rest of your life, because you're putting a foreign object in your body that wasn't produced by your body, and your body doesn't like that. It doesn't matter that you're putting a kidney in to replace a kidney. It's the fact that it's not your kidney. It isn't, native to your body, and it's foreign. Okay, so you take the medication for the rest of your life, and there's side effects sometimes to this medication. Prostate procedures, there's several of these, and you will see them a lot because it's very common. So a TURP is a transurethral resection of the prostate. A TULIP is a transurethral ultrasound-guided laser-induced prostatectomy. And then a VLAP is a visual laser ablation of the prostate. A TUMT is a transurethral microwave therapy. And so, yeah, it's a microwave. And then you have a TUNA, transurethral needle ablation. So what I would suggest is you go in and you just Google, or even do YouTube, and look at these procedures done so you understand how they're different. They can do cystoscopies, is usually the approach for transurethral procedures. So keep that in mind when for coding purposes. Breast biopsies can be done for men and women. Don't forget that. They're diagnostic in nature. Okay, so there's 2 types. We can do an open, so we just go in and grab some tissue, or we can do a local excision. When you do an excision of an entire lesion, that's not a biopsy. We're removing something completely. So don't get confused with that. If you remove the tumor or the lesion, that's not a biopsy. We're taking it out, but it's an excision. Okay. Now you can still biopsy the tissue, but it's not considered a biopsy. Breast reconstruction, there's several ways to have that done. They can do it during the mastectomy, right after the mastectomy procedure, or they can do it later and stage it. It depends on what type of reconstruction you're going to have done and how much tissue is taken in the mastectomy. So if you have a radical mastectomy or not, and they sometimes will use tissue expanders to allow for more skin to develop so they can put in a prosthetic. It just depends, again, how they do it. Whenever you do reconstruction of the breast, a lot of times you'll have tissue lap procedures. They will take tissue from the abdomen. They could take it from the back, the thigh, the buttocks, and reconstruct the breast that way. There are all different types. So one is called a TRAM procedure, transverse rectus abdominis musculocutaneous. They can do an LDMF, which is latissimus dorsi musculocutaneous flap. They can do a lateral transverse thigh flap, nipple or areola reconstruction. So sometimes they'll do that. And sometimes I've seen where women won't have that done and they'll just have tattoos put on. That's pretty cool. They had do a deep inferior epigastric perforator, which is a DIAP, superficial inferior epigastric artery, SIEA, or a gluteal artery perforator, or a gap procedure. Again, go in and look at all the different ones. They all really depend on, one, consulting with the plastic surgeon and your surgeon that's doing the mastectomy. What's the outcome that you want? How much of a mastectomy was done, et cetera, et cetera. So it's a lot involved to do that. They don't just automatically do one type. When we do flaps, they usually do pedestal flaps, and that means that you are keeping the tissue with its original blood supply and just moving it. Free flaps are when you're taking like tissue from the thigh and putting it back up. So pedestal flaps, no matter whether you're doing breast reconstruction or any type of thing, just remember pedestal flaps keep the blood supply. Free flaps are free from blood supply, okay? Let's see, when you do a free flap, the blood vessels are connected and use a microscopic surgery, and they take more time to complete because we got to connect all those blood vessels. When we remove stones, kidney stones, we talked about the ESWL, which is extracorporeal shock wave lithotripsy. It just explodes the stones, and then the body can expel them because it's smaller. You can also have percutaneous nephrolithotomy, and so they go in and they remove the stone via a scope. That's what I had. And then you can have ureteroscopic stone removal, and I had ureteroscopic stone removal. So they go in and they do go in through the urethra up into the bladder and remove the stones. They keep them in this little cage thing. But a percutaneous nephrolithopathy is they scope you. They'll go in from the outside, go in from the back. Sorry, got those confused. And that's it, guys. So I found this really cool. I'm really enjoying putting in these quotes. This one's from Peter Wright, and he's an artist. Said, I had been living with dialysis for 3 years or so. So think about it. 3 to 5 times a week you're going in, or 3 times a week for 3 to 5 hours. And says, and the new kidney felt like a reprieve, a new gift of life. I felt alive again, and I guess that has had an effect on my use of color. So again, that is pretty cool. I thought that was neat. If you have any questions, don't forget, ask them in the club. You can do them in your student SSH or the club proper, and we'll answer those. If you know anything about dialysis, or maybe a family member that's had dialysis, or even yourself. One of my best students had a kidney transplant. And like I said, it's like a reprieve of life. A lot of people, famous people, have had kidney transplants. Selena Gomez is one. Natalie Cole, Nat King Cole's daughter, is one also. But again, do some research on the kidneys and those procedures, because you'll see CKD is very common. And that's it. All right, guys. See you next time.